So the first protocol change that we're going to go over is we're swapping out D50 for D10. So now in your hypoglycemic patients, you're going to be using D10. It's going to come in a 250 ml pre-mixed bag, and you're going to give 100 milliliters wide open for the hypoglycemic patient. And just as you have done in the past with hypoglycemics, you can recheck their sugar, you can redose them with another 100 mLs as needed. The reasoning for using D10 over D50 are a few things. One, they don't have the rebound hyperglycemia that we were seeing with D50. So they don't come to the ED now with sugars of 400s. They need to be treated for that. And it's less toxic to the veins. So if the vein blows, it's not as big of a problem as it was with D50. And the studies have shown that it works just as effectively to raise the blood sugar, and it's not allowing the drops in blood sugar any more than D50. Protocol otherwise is the same if you don't have an IV. Some studies of oral glucagon, and the refusal protocol is still the same for these patients. So that's the first change that's going to be happening the quickest, essentially. As soon as all the training is done and they have the D10 in stock, so soon, hopefully September 1st. The second thing is just kind of a clarification. With OB patients, 20 weeks and above, they're going to go to the North Tower at Chance, to the PTD where they can go straight up to labor and delivery. You know, in the past there's been questions whether it's 16 weeks, 22 weeks. So 20 weeks, they go to the North Tower. Just like you call a trauma alert on a 20-week pregnant patient, 20 weeks is going to go to the North Tower. So the next protocol change that's coming is it has to do with cardiac arrest patients, the medical cardiac arrest. It doesn't apply to trauma. We want you to stay on scene with the cardiac arrest patients 20 minutes delivering good quality CPR. Okay. And this is manual CPR, not audible CPR. Studies have shown manual CPR is better than audibles. And the studies have also shown that CPR is really what makes a difference in these patients with cardiac arrest. So we want the fewest interruptions possible during CPR. And any movement of the patient is going to interrupt CPR. And every time you interrupt, that compression fracture that you're building up decreases all the way back down to 0. So with as few as 30 seconds, all the work that you've done is essentially negated. So we want to keep the breaks in CPRs down to the minimum. Okay. Obviously, if you're in a situation, if you're in a public place, if you feel unsafe, if you have 50 people surrounding you and you feel that you need to load the patient and go to the hospital, you still can do that. But we want to try and stay on scene and deliver care that way. This is patients, in a systole PEA. We realize that there will probably be more termination and resuscitations on scene, and that's okay. The docs at Shands that take medical control have been told that they might get more calls for termination, and that it's okay to terminate on the scene.
That more the teaching behind this is that we're trying to terminate sooner and spend less time on something that's not.
No, it's to deliver high quality CPR that's uninterrupted.
So after our 20 minutes, that's just
so
20 minutes, then we decide to go from there?
Yes. There's going to be a new termination of resuscitation and termination of death protocols that are going to come out as well. That will help you determine whether to call the resuscitation or not. And obviously, family members will be like, why aren't you taking my family member to the hospital?
At JCPenney's for 15 minutes in CPR, the family's going to be screaming like hospital girls.
Like
And you have to tell them,
public
you're gonna wait there 5
places,
minutes.
yeah. When you feel like it's not appropriate to be there, then it's fine. But sorry,
What about pediatric?
this is for adults.
Just adults?
Peds,
So 18 below, or?
18-year-olds, 20-year-olds are probably gonna want to go to the hospital, but these are like your 40-year-olds.
We haven't determined what age where that break is going to be as far as pediatrics. If it's going to be 16, if it's going to be 18, we haven't worked that out yet. And again, if anytime you feel, whatever the situation that might be, you're not going to be faltered if you want to do a load and go situation anyway. But this is mostly at a residence, and not a residence where there's a family reunion, there's 50 people there, but a residence where there's just a family member and somebody
Nursing home.
is it
Yeah.
nursing home.
You can work it at a nursing home. I haven't been to the nursing
Yeah.
home, seriously.
But, you know, basically, there's an educational component to this too, that somebody's talking to the family member saying, we are doing everything here that will be done in the emergency room. We're giving the same medications, and at any point, we can always call medical control on the radio and tell them what's going on and let them make the determination if we want to. So, and as Jessica mentioned, you know, in our determination of death protocol right now, on the flip side, on the back side of that, on the second page is the termination of resuscitation. We are taking that completely out of determination of death. And we're going to revamp the whole determination of death protocol, and we're coming up with a new protocol for termination of resuscitation. So if you work this situation for 20 minutes, again, PEA or systole, and you have not got any results, there will be certain bullet points that you will say, this is when you can, if you confirm this, you can stop and call and call the person deceased. But nothing still doesn't preclude that you cannot go ahead and call medical control just to get that warm fuzzy feeling.
Isn't that how it's written now?
Yeah, I mean, it's.
Yeah, and it'll still be written in there too. But
So after-
but you can, there'll be certain things that you can go ahead and terminate without calling medical control.
Isn't it written in there now that we terminate without medical control?
On certain things, yes, you can.
ACFR.
But again, when we split this out,
Right.
yeah, but when we split it out, we're going to make sure it's
Okay.
pretty ironclad.
Okay.
If you do get return of circulation during those 20 minutes, you can go ahead and put the auto pulse on for transportation in case you lose pulse or to the hospital. Also with cardiac arrest patients, these are the patients in VTAC and VFib, patients that are refractory to 3 shocks. So you've shocked them 3 times, they're still in VTAC and VFib. We're going to try the double shock. So you have the pads on, you know, in the front like you normally would. Now you're bringing a second monitor and put one on the front and one on the back. So a total of 4 pads, and you're going to deliver 2 shocks at the same time. If the monitors are close enough that one person can push the buttons together, otherwise you have 2 people on the monitors and count 1, 2, 3, push a button so that they get 400 joules at once.
Is it on 3 or 3?
You can determine that. And these are mostly going to be patients that are more obese because they have more impedance to the electricity with all their adipose tissue.
So, you said manual CPR is better than auto pulse.
Correct.
So, my understanding was when we got auto pulses, they're like, use auto pulses on every cardiac arrest. So, we're kind of getting away from that?
And we're going to kind of get away from that because research has shown that even with the auto pulse, Dave, you always have that pause when you're trying to put it on and everything else like that, where if you go in and you basically change compressors out every 2 minutes and you're uninterrupted, and especially when you continue compressions while you're charging the defibrillator if you have to deliver a shock, if you got a shockable rhythm, then you get that threshold that's built, that perfusion threshold that's built up, and it doesn't drop off. Because the minute you stop, that perfusion threshold drops considerably, very quickly.
How long does it take to build it back up?
It takes probably a good 15, 20 compressions before you build it back up again, maybe even 30.
There was a good video that I was showing students online that actually showed
Yeah, the graphic that kind of
Yes.
shows it creeping up.
Yeah, it was
and then
a,
as soon as you stop, it goes.
ultrasound of the heart while they're doing CPR, and they stop and just watch the blood start to coagulate, and they start compressions again. It's probably 15, 20 compressions before you finally start seeing the blood start to flow through the heart again.
Any questions about any of those protocols? Okay. So now we're going to go over the race score. Hopefully you guys watched the target solutions on it. So this score is to look at whether or not patients are having a large vessel occlusion versus small vessel occlusion. Okay? It doesn't affect calling a stroke alert. All of that is still the same, but now when you have these stroke patients, we want you to calculate this score. The reason being that if a patient has a large vessel occlusion, they should very likely go to a comprehensive stroke center. TPA has not been shown to be very effective in the large vessels because of their low flow. They're not getting return of their functions just from the TPA. But an endovascular procedure can be done to actually remove the clot, and it decreases the morbidity and mortality in these patients.
By how much?
Considerably, I don't have the actual.
That's a significant amount.
I can say for a large vessel, for example, like a basilar, in the back of the brain, TPA only we can analyze is in 4% of patients.
Wow.
And I think MCA is about 25-30%.
Wow.
So the endovascular therapy is definitely needed to open the vessel up.
And just like with TPA, time is
What's
brain.
the time frame for it?
For which part? The endovascular?
Yeah.
We take up to 8 hours, but the 12 hours as well, depending on the case. Like if it's a young dude and who on our who take it, there's enough salvageable brain, they'll take them. Make sure.
So
give them
we
the
still
shot.
use the same, like, what was it, Cincinnati
Cincinnati.
stroke assessment or whatever, to call stroke alert, and then on top of that, you're going to this
Severity
number.
score.
This is a score that you're going to document in EMS Pro. It's under the exam when you get a stroke, it'll be there. And also something that when you get to the ER, you're going to say this is the race score, and it'll be conveyed to the people. Okay. And right now we're just collecting data. So we want, because this is a score that has been validated. There have been studies done on it in big studies in Spain that validated that it works. And it's being used other places in the country to direct stroke patients to a comprehensive stroke center. We just want to see if it works in our area. So we're going to take your scores and compare it with the outcomes of the patients if they did indeed have a large vessel occlusion, and then we can make adjustments as we move later on. So right now we're just looking at the data, not saying that they should go anywhere yet. So to do the race score, most of the stuff you already do, okay? You're gonna look at their face, look for any facial palsy. If they have no palsy at all, it's 0 points, mild, it's 1, moderate to severe is gonna be 2 points. You're gonna look at the arm and leg motor function. If it's normal to mild deficit, they get 0 points. Moderate, they get 1 point, and severe, they get 2 points. And you're going to look at head and gaze deviation. So if they have any deviation of their head or their gaze, they're just looking to the left, can't look to the right, that's 1 point. Either they have it or they don't, so 0 or 1 point. Okay. The next two things, aphasia and the agnosia score, you only do one or the other, okay? And it's based on the deficits that the patient has. So if the patient has right-sided paralysis, you're going to do the aphasia screen. And if they have left-sided paralysis, you're going to do the agnosia screen. Okay. So with right-sided paralysis, doing the aphasia screen, you're going to ask them to close their eyes and make a fist. Okay. If they're able to do both tasks correctly, they close their eyes and make a fist, everything's fine, they get 0 points. If they can only do one task correctly, they can only make a fist. They can't close their eyes, that's 1 point. If they can do neither task, then it's 2 points. Okay. So you're testing their ability to perform these things.
Can you say close your eyes and make a fist?
Yes. If they have left-sided paralysis, you're going to do the agnosia screen. This one's a little bit more difficult. You're going to point to their left arm, which is where they have the deficit, and you're going to ask them, is this your arm? If they're able to say, yes, that is my arm, they get 0 points. Okay? If they say, no, that's not my arm, or they just stumble, can't answer you, that's 1 point, because they've done the tasking correctly. The other task you want them to do is to raise their arms and clap. Okay, if they recognize that because of their deficit they're unable to clap, they say, no, I can't clap, I can't move my left arm, that's 0 points. They've recognized they have the deficit. If they try to clap, or if they say, yes, I can clap, that's a point, because in fact they cannot. Okay, so 0 points if they recognize their arm, and if they recognize that they are unable to clap. 1 point if they either say, I can clap, or if they say, no, that's not my arm. If they do both of them, say, that's not my arm and I can clap, then that's 2 points. Okay? We only want, make sure you only do one or the other based on their paralysis,
Okay.
because if you include both, you're going to get a total of 11. The score only goes to 9, and it'll falsely inflate the score. Okay? 9 is more severe. The closer to 9, the more likely they're having a large vessel occlusion. So in the future, we would be able to say if it's like 5 or higher, they should go to a comprehensive stroke center, if we're able to validate this for our region.
So again, we're going to let you know when we're going to go live with this. We're going to be collecting the data on the ePro. There'll be the race 0 through 9, and you'll get basically just whatever the total score is you get. If the engine gets there before the rescue does, you can always give them the scores, we've had a chance to score it out. They don't need to take another one unless they want to. And you'll give, like I said, they'll give that to the doctor when they get to the ER. It will not be called out over the radio, just still call stroke alert over the radio. We can pull that data out, and then based on what patients we shoot to them as far as stroke alerts, we'll put that data in, that what this one was a race 4, this one was a 2, this one was a 9. Then they can look at the patients and see what the ER got as far as the NIHSS score. And then we'll take into consideration, you know, we'll look at the ones at North Florida, that goes to North Florida, the ones that go to Shands, and then down the road, after 4, 5, 6 months, whatever we determine, we'll determine what's that magic number on the race score that says they go to a comprehensive stroke center over a primary care stroke center.
I can make a copy of this, turn in with my report.
Yeah, just stay with the patient, basically.
I'm a little old school, I write everything down.
I mean, it can, and I don't know the patient contact form that we come up with, we can look at maybe if there's a place to put that on there, or just put the race score on there once you total it out.
Is there a reason why you wouldn't be able to call it in on the stroke alert, so when the page comes across, it says race 5?
I mean, well, we could, I mean, that's.
And you probably want your stroke alert to go before this is even done.
Yes.
It's gonna be awful. I mean, if I'm coming out from somewhere in Archer, I'm gonna have plenty of time, no big deal. If I'm coming from in town,
Yeah.
realistically,
Right.
I'm gonna have to go look for this paper in my notebook, pull it out, and then do it. Probably won't have time. I mean, I will, if you tell me to.
Time transport.
I mean, you can do it on the truck, I mean, these are simple tasks, it really should take just a minute or two, but we don't want it to delay the stroke alert.
That depends on how bad
Well,
the
that's-
patient is.
Yeah, if the patient's really sick,
Plenty of-
their score's
yeah,
gonna
you're
be
not
9,
even-
you know,
you're just
that's
trying to
fine,
manage them.
yeah.
9.
Yep.
You'll get good at
So
it.
is that, I mean, somebody like that, they're just 9.
Yeah, if they're not doing anything, yeah.
Unconscious.
Mhm.